So before we start on the topic, I just want to do a quick company, a few words. So we are Calpro, and Calpro is a Norwegian-based company focusing exclusively on calprotectin assays as a general for inflammation, as an inflammation marker, but specifically for diagnostic, differential diagnosis and follow-up of patients with IBD. And we are a part of a Swedish company group called SVAR Life Sciences. So we have been in the calprotectin business since early 80s, and the reason for that is that those who initially discovered calprotectin were those who later founded the company Calpro in the early 90s. So we do have a long, well, we have a lot of experience in the company when it comes to calprotectin and the way it was developed, and have developed into a biomarker for of choice for IBD patients as it is today. As mentioned, we're part of a Swedish company with quite a few different offerings. We also have a lab service that is based in Malmö, along with the main company headquarters, while SVAR is based in Oslo. Yeah, so the thing we are going to talk about today are key benefits of CalproSmart self-test for IBD patients. Now, the topic was chosen just to sort of go in depth on common arguments that are presented for using rapid test or home test for IBD patients. But there are also certain concerns that we quite often find with physicians or hospital clinics. So I will touch up on a few of these today. And as I mentioned earlier, if you have any other points that you would like to discuss, feel free to ask, and we can sort of go into details on that as well. The points that we are going to go through today are three commonly used arguments for self-testing for IBD patients. The first one is that early intervention reduces time to remission. The second one is that distant management has quite a few positive effects for the clinic as well, not necessarily only the patient. But the most important one, obviously, is the patient, and that it increases the quality of life for the patient. The key concerns and questions I will touch upon are the two mentioned here. The first one is, can a rapid test be trusted? There is a notion that they are not as accurate as lab tests, and hence it should not necessarily. Well, some people are a little bit concerned because of that they're not as accurate as lab tests. So we'll touch up on a few points on that, and then also to another concern that we quite often get is, how is it when you use assays from different suppliers? So we will have a lab test from one supplier, and you will have the rapid test from another one. So we'll touch up on that as well. But let's start with the benefits first of distant management. So the first point was, early intervention reduces time to remission. Now, for those of you who are in contact with IBD patients, and if any one of you have IBD yourself, to have a full-on flare for the patient is really bad. I mean, the flare itself is one thing, but what follows it is makes it a lot worse. So the symptoms, the clinical manifestations of the disease. There have been a lot of studies showing how to sort of detect the flare as early as possible and have it treated. And the reason for that is that many studies do show that by having an early intervention, you can actually reduce the time the patient will spend in the flare. And quite often you can actually avoid the patient becoming clinically ill as well. So there was a large-scale study done in Denmark published a while ago, which showed that by having early intervention, you can actually reduce the time it takes for a patient to get back to remission. So you have a patient who will flare up, and then you start the treatment. And they showed that by early intervention, you can actually reduce the time to remission from 77 days, that's 2.5 months, to 17 days, which is half a month. Now that is a really significant difference, and it allows for the patient to get back to normal, their daily routines quite much easier. The reason for this difference was that one group of patients were followed with standard care, which was the normal approach. The patient would go into the clinic or contact their treating physician once they started to feel the clinical symptoms of the flare. Now, once the patient approached the doctor, it will take some time for them to get into the clinic. Then it will take some time for testing done and some time to confirm and then put on medication. And then there's a lag time from the time you start with the medication until it has an effect. So during this entire period, this patient would experience an increase in inflammation and hence increase in symptoms. Now, they compared this with a distant management and sort of a web-based approach where they saw how patients could have, it would be much easier to detect a flare-up at an earlier stage by continuous monitoring of that patient. Now, the continuous monitoring in this study, now it's not this one, it was another study done, was that they would allow the patient to do a symptom score feedback, and they would also allow the patient to send in calprotectin sample. And the sum of this would determine whether or not the patient was in flare or not. Now, during this study, they showed the reduction in time. And for quite a few of them, there were no flare-up. It was a subclinical detection. And this was due to the lead time that the patient would sort of be saved from. So by entering into an ongoing flare at an early stage, they could start a intervention earlier, and they could reduce the time for to get back into remission. There has been a lot of studies on this. So there was a study performed in a study called CALM study, which was performed in 2016. This study was done for patients with Crohn's disease, which actually showed that by tight monitoring of the patient, they could actually reduce an increase in level of inflammation. So a standard care, in a group of standard care, the patients, 35% of the patient actually had an increase in inflammatory levels, while in the control group, which they followed up and monitored with apps, patient-reported outcome apps, so symptom score apps, phone telemonitoring, so they would have discussions with their physicians over the phone or other channels, they actually managed to have none with increase in their Crohn's disease, which actually supports the notion that monitoring over time allowed for a better intervention and a better care of the patient. And these kind of studies have been more and more performed more and more frequently in order to support distant management of IBD patients. And with the recent or with the ongoing pandemic and COVID-19, it has placed even more pressure on the hospitals to sort of find alternative ways of treating patients and allowing chronic patients to get out from the hospital and be treated at a distance is definitely one of the options that will become more and more prevalent in hospitals. Now, the effect of such a distant management on the clinic is also significant. There has been a lot of studies showing the e-health, the benefit of e-health, and how it affects both the patients and the hospitals. For the hospitals, it is quite commonly seen that it reduces the amount of acute and routine visits into outpatient clinic. And also it does also reduce the level of inflammation where the patient will come into the clinic, right? Because they will be brought in much earlier. There was one study that pointed out that there was a reduction of about 16% less clinical relapses among a test group, while also reducing the number of hospital visits. Now, this is really important because the queues in the hospitals tend to be really long, and any way to sort of reduce the lines are important for good treatment and quality of treatment of the patients. There was actually an NHS study in 2012 which showed that distant management with only symptom scores freed up to estimated 400 appointments throughout a year, which is a lot of appointments that could be used to patients who really needed it, instead of having to have every single patient come in without any necessity or the need to do. There was actually a recent Dutch study that was also performed, which supported this notion, using only patient-reported outcome apps. So the patient would basically put in their symptoms into an app, and based on that, the physician would follow them up, either bring them in for consultation or give them advice or the phone to change their medication. And this also showed a significant reduction in outpatient visits as well as admissions. Now, there has been a lot of other studies showing reduction of admissions, severe cases, reduction in endoscopies performed, even surgeries, and so on. But this is a field that is developing within research, and it is there's a lot of research going on, but this obviously takes time. But it is not inconceivable that the outcome of distant management and e-health will really have a positive impact on flares, sick days for the patient, but also hospital visits, admissions, as well as endoscopies and so on. So there is a lot of work going on, but obviously we need to wait until we have more data on this. The third point is that which is probably the most important for the patient, is that distant management actually increases the quality of life of the patient significantly. In Calpro, we had a patient who visited us a couple of years ago, and this patient, she made a comment which was really important. She said, using CalproSmart or self-test and distant management, I don't feel like a patient anymore. For her, this was actually life-changing, because she said, I don't need to go to the hospital every so often. Now I don't need to go in to hand in samples. I don't need to go in and just go in the corridors and for appointments and checkups. And I'm not getting as much sick. I think she said that she hadn't had a flare in 4 years or so after she started using these e-health platforms. Now, this is the key outcome of distant management of IBD patients. The idea is to treat them as early as possible, reduce the days where they are sick, give them a little more confidence and support in terms that they know if they feel bad, they can perform a test at home. They don't need to go to a physician, wait for a week or 2 weeks until their appointment comes, and so on. So this do empower the patient quite a lot. And that empowerment definitely affects their quality of life. Now, there was a study which was performed by NHS for distant monitoring, and that study showed that 90% of the patients were quite happy with the follow-up they did receive being managed at a distance. They didn't have the need to actually go in to see a physician without it being critical for them. And this was quite positive for them. We also had our own customer satisfaction surveys done where patients who are using our rapid test have shown that they are really, really happy with the option of using a distant management tool. The increase in quality of life is obviously related to early detection, early treatment, and subclinical treatment and so on. But for us who might not be in the case some of these patients are in, it's as easy, it's as little as to not having to go to the hospital with a stool sample in a bag. Just to be able to perform tests at home, just to be able to go along with the day without having to have it interrupted by hospital appointments, tests, follow-ups, etc. All of that makes a lot of difference. So the e-health management is something that the patients quite often really approve of. Now, you will always have some that it doesn't fit for, right? But imagine in a hospital setting where you have 50, 60, 70, or even 80% of the patients who would be managed through e-health. It will open up a lot more time. It will make it will even affect the quality of life of the other patients who want to have the standard care due to reduced queues and easy access to their physicians and so on and so forth. So it definitely has a benefit to it. Now, there are certain concerns that are raised. Mostly these come from the physicians, but sometimes also from the patients. The first one is, how can I compare the results with the lab assay, especially if it's from a different supplier? Now, this concern is based on the fact that different suppliers will calibrate calprotectin assays differently. And there will be a significant difference. Now, just to give an example, one of our competitors, if we measure the same sample in both assays, our number will be normally half as high as theirs. Now, it doesn't mean that one is correct and the other one is not. It's just the calibration is such that the value provided is significantly different. But that doesn't, it still sort of gives you the same information, because our cutoff level for when you have an inflammation will be half their value as well. So everything will follow sort of like be twice as high for their data and half for ours, right? Half of their values for ours. Now, what is important in these kind of cases is to use the reference that the supplier of the test has given you. So you cannot perform a test on our assay and go to their references and say, oh, this and this value means such and such. It's important to have the same reference. As long as we can keep that, it doesn't make any difference which supplier you go to. For the rapid test, it's even easier. Our rapid test, as you can see on the image, has a color-coded presentation of the disease level. So even if the number might differ, the classification in and of itself does not. A patient with moderate level of disease activity in our test will also have a moderate level of disease activity in our competitors' assays, right? So for those clinics, hospitals, or patients who have a different supplier of lab assay, it is sufficient to be aware that at least our CalproSmart values are presented as semi-quantitative results as well. And this makes it much easier to transfer the results from our assay to any competitor assay without having to worry about the difference in calibration. This is, that's the easiest approach to this. Now, the second one is, can the rapid test actually be trusted? And the short answer would be yes, of course. It is a test, it does measure calprotectin level, and it will give you a feedback. Now, this question often arises from the notion that lab assays are much more accurate than a rapid test. That is true. There is a lot more variation on a rapid test compared to a lab assay, but there are certain points that makes this still usable, and that is that in a active disease, the calprotectin levels increase so much. So from a baseline, no disease activity to a moderate disease activity, you can have a 5 to 10-fold increase already there. And then up to a severe disease activity, there's another 2-3-fold increase, right? So because of this, the amount of increase that occurs in active disease, the variation that you have on a rapid test, it doesn't make any difference. But still, obviously, we do have data to show that this is still correct. So this is a internal validation that we have done here, where our CalproSmart assay has been compared to our ELISA assay, our lab assay. And you can see the test results pretty much follow the trend line, so the correlation between these two assays. We do see a slight increased values for CalproSmart, so they give slightly higher results than the lab assay, but that is actually quite okay, because this results in us not showing anything with false negatives in it. So you don't sort of tell a patient you're okay when they in fact are in a process where they are having a flare. So it will show a slightly higher level of calprotectin compared to the lab assay, with really good sensitivity and specificity. But we also have seen from different publications that our assay is quite well correlated with some of our competitors, such as this one, Fadia, showing really good correlation. Same here, on the line or slightly above, but really good correlation. So they definitely are interchangeable in the sense that you can trust your home test to give you a result that would show you a direction where you're going, where the patient is going with their inflammation, right? If the calprotectin level is elevated, then you can see that something is going on. Obviously, this is not the only source of data that you would get in from a patient. You would also get their symptom scores, how they're feeling, how often they go to the toilet, etc. That would be the data that you would need to decide whether or not this patient is in the flare or not. But the correlations are really good. Another way to actually show that the tests are comparable is by doing a concordance study. So here what we have done is that we have had our lab assay and compare that to our rapid test assay. And we have 3 levels of activity, disease activity. So the green one is low, the yellow is moderate, and then you have the red one, which is severe. And the most important thing with these kind of setups is that there are no green ones that are shown as red in either ways, right? Or no red ones that are shown as green. Because there is some variation, the bleed over to the next category is expected. But I will come back to that in the next slide. That is also expected from a point of view of the sample in and of itself. Now, this is a study that was done quite early, quite a few years ago, by a hospital in Oslo. And we see that although there are some bleed over to the next category, there are never bleed overs to where a category is jumped. So that would be the corners. There are 0 tests where it was shown either as a low disease activity in the lab test and severe in CalproSmart, or the other way around, that it was shown as low in CalproSmart and high in the lab test. And this is something that we see from other studies done as well. This study was done in Malmö University Hospital, showing the same trend. You have majority of the assays obviously are correct in terms of their placement. That would be the green, and then we have the yellow shift here, which is one category to either side. But there are never situations where a category has jumped from low to severe, so from low to severe, or the other way around, or severe to low in that sense. So that would be this way. This is also this has also been shown for the FADI assay, and they even tested quite a few samples. So we see that the correlation is really good. We have more than 50 patients that were classified right in low, 30 patients in moderate, and then they had a few samples of severe. But there are no one that jumped from either low in CalproSmart to low in the lab test to high in the CalproSmart, or the other way around, that you had someone who were severe who jumped the categories in either ways. This is really important. and I'll just come back to it here, because there are, as I said, there are two ways to do this. The jumping off category, they can be a false positive. So you have someone who is not ill, they don't have any flare-ups, but the rapid test will show them as someone with a flare, right? In this case, what happens is that the patient will normally be followed up by the clinic one time more than they would have needed to, right? Which is okay. I mean, the outcome is simply that the patient will be tested a little more than they needed. What is critical is when we have a false negative in an assay. And that is when a patient who have increased level of calprotectin in their stool sample, indicating an active and ongoing inflammation, and at a severe level, is classified as someone who is healthy. The consequence of this is that the patient will postpone their treatment, and a week, 2 weeks postponed will have a lot of negative effects for the patient. They will increase in symptoms, they will increase in pain and inflammation, and will hence prolong the time required with treatment to get back. This was a study which was performed in I think it was Belgium, where they actually tested a lot of patients. So you see in the mild category, you have 273 patients. That's the large group. And even in severe, they have 78. What they discovered is that our assay had a 2% rate of false positive. So that would mean 2% of the patients who, when tested with the lab test, showed low level of inflammation were shown as high in the rapid test. And these are these 11 patients. So out of 280 some patients, 11 had an increased level. Now, we did not have any false negatives, so this is a large study, and that's why the data is quite good to look at. But what we did see is one of our competitors to a comparison, they had 8% false positives, and the third one had 0.8% false positives. The problem here for one of our competitors, and a good thing for us, was that we didn't have any false negative results, which is the most important thing in this. While our main competitor had 4.2% false negative results, which means that 4.2% of the patients who in fact had severe disease activity were shown to be okay. And that is really high. Now, this study showed us quite a few things. One was that training is really important. And that's why some from our team, especially Lina in Denmark, she conducts training for patients and onboarding herself to sort of include the patients and have all the questions answered and show them how to the test is performed, right? The second thing that it shows us, and it is important to keep in mind, is that calprotectin is not a standalone marker for treatment modification. So you cannot have a adjusting treatment for a patient based on calprotectin levels alone. There need to be more of a package, and the package is often symptom scores, and how the patient is feeling, and how often they go to the toilet, the quality of the stool the stool they have, if there's blood and in the stool, and so on and so forth. So it needs to be like a package deal where calprotectin is the objective marker. but the patient's symptoms needs to be taken into consideration. The third thing that it shows with all the light gray areas, which was one category shift, is that the stool sample is not a homogeneous sample. And this is definitely true. So it is possible to take one stool sample, analyze it 2 times, and get really different results. It all depends on where in the intestinal wall the inflammation has been, and how the stool is, if it's completely liquid or if it's hard, how much exposure it has had to the size of inflammation, and so on. So there are a lot of factors that sort of affect the outcome of a calprotectin assay, and that's why it needs to be taken in collaboration with the patient symptom scores as well. It cannot be a standalone decision maker in of itself. And these, the non-homogeneous nature of the sample also affects, obviously, comparisons. But what is important to know is we don't have any false negatives, which is really important for the patient and in patient treatment. So just to summarize quickly, what we do see is that distant management is definitely a trend in follow-up of chronic patients, especially IBD patients. And this has even been further strengthened with the COVID-19 and limitations on hospital visits and so on. So it's definitely something that we see in the market, that more and more hospitals are considering or opting for this. And in these kind of situation, it is really important to have an objective marker for the patients to provide complete feedback to the clinicians and give them the information they need to change their treatment or ask them to come in for further investigation. Now, distant management definitely increases the quality of life, not only because it reduces the time in flare, but it also the time in flare and getting patients back into remission, but it also gives the patient a sense of freedom and control in a situation where the condition quite often have taken over the control quite a lot. And since these assays are done online or using mobile phone applications, they can be performed anywhere in the world. So you don't need to be limited to having to come into the hospital and provide a sample and do a checkup. You can do it anywhere in the world, and the results will be presented to your physician, and they can guide you accordingly. Now, one of the benefits of distant management is that it also allows the hospitals to give priority to those who actually need their help. Because in a clinical situation, there will be a lot of patients coming in with concerns, not necessarily active disease, but it might be anything that triggers them to reach out to the physicians. So by having distant management, you can allow for more and more patients to be treated and followed up digitally, giving the hospital time to give priority to those in need and those in active disease and those in with severe disease activity in of itself. Like I said, rapid tests are solid assays, although they have a variation, but the variation, especially in case of calprotectin and stool samples, do not have much to say. There will be slight variation in terms of the numerical value of the results, but the classification of the patient will be correct in terms of low, moderate, or severe disease activity. And as mentioned, you don't really need to have the same lab assay as the rapid test, because you can always use the color-coded references to compare to the lab assay. And you can always use the rapid test as a screening for bringing the patient in to perform a lab assay if you would need to have the results to be the same as the lab assay. So a patient can be home, perform an assay showing high, moderate value, and this patient can then be brought in to do a lab assay to confirm the results, to have it on the same level as all previous results this patient have had. Last and finally, CalproSmart does work, and it works really well. And we know this because we see the increase in requests from all over the world, but also from pharmaceutical companies wanting to give a little extra to their patients or performing studies. And as I always say, pharma companies are really, really reluctant to work with anyone unless they are 100% sure that the tool they bring in will actually work in a real clinical setting. So the fact that we have so many projects ongoing and so much interest ongoing from pharma companies, it actually supports our notion that CalproSmart does work well for clinical applications.